All right, a big welcome to your renal rotation here at KTPH. Think of this as your practical survival guide for peritoneal dialysis, or PD. We're going to cover exactly what you need to know to hit the ground running from day one. So picture this. It's your first week, a patient is ready to start on PD, and you're the one handling the referral. I know, it can feel a little daunting. So what we're going to do is build a really clear framework you can use for everything, from that initial consult all the way through to troubleshooting common issues later on. To make this really practical, let's follow a case. So meet Mr. Chen. He's 65, he has end-stage kidney disease, and after talking through all the options, he's decided to start on PD. We're going to follow his journey to see all these core principles in action. So why PD for someone like Mr. Chen? Well, for starters, it's a home-based therapy, and that gives him a ton of autonomy and control over his own life. It's also known to be better at preserving any leftover kidney function he might have, what we call residual renal function, or RRF. And really importantly, it's much gentler. It avoids those big, rapid fluid shifts you see in hemodialysis, which is a huge plus for patients with any cardiovascular instability. Now, how does this whole thing actually work? Well, the real magic is in the peritoneum itself. You can think of it as the body's own natural, built-in filter. It's this amazing semi-permeable membrane that lets all the waste products and extra fluid move from the blood into the special dialysis fluid that we put into the abdomen. It's just really elegant physiology at work. Okay, let's get down to brass tacks. Here is the established KTPH pathway that's going to get Mr. Chen from his initial referral all the way to his very first dialysis exchange. The whole process kicks off with pre-op prep, of course. Then, one of our nephrologists inserts the Tencoff catheter. That's our standard curled tip one, usually just under local anesthesia. Right away, we flush it to make sure it's patent and everything's flowing. Now, the key thing to know about our process is the urgent start protocol. This actually lets us begin with low fluid volumes just 1 or 2 days later. Full volume dialysis then starts about 2 weeks after the op, once Mr. Chen has gone through all his training. Okay, now for your part, writing that very first PD prescription. Here at KTPH, we have a really standardized and safe way to approach this, so you'll feel confident right from the start. We always begin with an empirical approach. It's a reliable, works for most starting prescription. So for Mr. Chen, a pretty typical start is 4 exchanges a day. That just means 4 cycles of filling the abdomen with fluid, letting it sit there for a while, that's the dwell, and then draining it all out. We'll use 2-liter bags and alternate between different glucose strengths to help manage how much fluid we're pulling off. You're going to come across a few different types of these dialysate bags. The main difference between them is the osmotic agent. That's the active ingredient that does the work of pulling fluid out of the blood. Most of them are glucose-based, like Dianel, but we also have solutions that use amino acids or a polymer called icodextrin for very specific clinical situations. Okay, I really want you to focus on this critical difference: standard glucose solution versus extraneal. Extraneal is perfect for that long overnight dwell when the fluid is in the abdomen for over 8 hours. But, and this is a massive patient safety alert, so please listen closely, its metabolites can cause a falsely high reading on certain point-of-care glucometers. This is one of those things you absolutely, positively must always remember. All right, fast forward 2 months. Mr. Chen has been doing great, but now he's back in the clinic with a really common problem. So let's work through it together. He comes in and tells you his legs are all swollen and he's feeling more breathless than usual. Your immediate thought is probably fluid overload. So what's the very first question you should be asking yourself? What's your approach? Before you even think about tweaking his prescription, the first question must be, is this a mechanical problem? I mean, there's no point changing the fluid if the plumbing is blocked or, springing a leak. You always have to rule out a physical issue first when you're troubleshooting poor drainage. So on your physical exam, you're looking for very specific clues. Feel the abdominal wall. Is it swollen or boggy? Is there a really obvious leak right around the catheter exit site, or has the fluid tracked down, causing scrotal or labial edema? These are the classic signs that you're dealing with a mechanical leak. So, once you've done your physical exam, the next step is to turn to the data. Remember, your patient is tracking their numbers every single day, and that little logbook they carry around often holds the key to the diagnosis. Ask to see their PD logbook. What you're looking for are trends. Has the net amount of fluid he's draining each day been slowly going down? Has his weight been creeping up? Are his blood pressure readings getting higher? I'm telling you, this logbook is a gold mine of diagnostic info. And in Mr. Chen's case, you find some bogginess around the catheter site. And yep, His logbook confirms poor net drainage. The diagnosis is clear: a pericatheter leak. The immediate management is actually pretty simple. We just need to rest the peritoneum. We stop PD for a day or two. Sometimes the patient might even need a short stint of temporary hemodialysis to tide them over. So there you have it. We've walked through the basics and a super common clinical scenario with Mr. Chen. Let's boil all of this down to the three most important things for you to remember during your rotation. First, trust the protocol. Our empirical prescription is designed to be a safe and effective starting point for pretty much everyone. Second, when things go wrong, always think mechanically first. And third, please never ever forget the extraneal effect on certain glucometers. It's an absolutely critical patient safety point. And that's really your quick primer on PD. We've managed Mr. Chen's acute leak, which is great, but that just leads to the next question for you to think about. How are we now going to optimize his prescription to make sure he has the best possible clearance and fluid balance for the long haul? That, right there, is where the real art of nephrology begins.